Good afternoon, everybody. Um, Today, the grand round is being presented by the Department of Medical Oncology. Professor Atul is not here. He is not well. So I will start with the introduction. The title is The Tenets of 1000 PNETs, 15 years of reviewing ewing sarcoma at AIIMS. The schema of the CGR will be as follows. We'll first introduce PNET. We'll then Dr. Deepam, who is a faculty colleague with me, will talk about the diagnosis and principles of therapy. Dr. Love Kapoor from orthopedics will then talk about the surgical management. Professor D.N. Sharma will then talk about the radiotherapy in this disease. Then Dr. Archana and Raghav, both DM residents with us, will talk about the experience of this disease for last 15 years at IRCH. I will then conclude and give my views about the way forward, and then we will have some question answer session. So in 1918, PNET was first picked up as a small round cell tumor involving peripheral nerve cells. And then in 1921, Dr. Ewings first described the same tumor in the bone. And in 1984, it was shown that both these kinds of tumor have the same cytogenetic translocation, that is 1122. PNET is an aggressive bone and soft tissue tumor. Majority of these tumors occur in the bone, but soft tissue involvement primarily is also known. The incidence is 1 case per 1.5 million, and it happens to be the second most common bone tumor in children. The peak incidence is 15 years. So bone tumors are mostly seen between 10 to 30 years of age. In terms of total sarcomas, we have from 2003 to 18, the data is from 2003 to 18, we have more than 3,600 sarcomas registered with us. Of these, 30% are PNETs. This is the rough distribution of the 3,600 cases over a 15-year period. Almost the ewings and osteo are almost same, and soft tissue sarcomas are 1,200 out of the 3,600, and 350 odd are the rhabdomyosarcomas. I will now call upon Dr. Deepam Pushpam to speak on the diagnosis and principles of therapy.
Good afternoon, everybody. Ewing's sarcoma usually presents with pain and swelling of the long bones, but axial skeletons may also be involved. Approximately in 20 to 25% of patients have systemic symptoms such as anorexia, fever, weight loss, and anemia. So the first So the first investigation that we do is the radiograph of the affected site. Classically, it presents as a poorly marginated destructive lesion and associated with the soft tissue mass. The classical appearance described is onion peel appearance, which is due to reactive bone formation due to periosteal reaction, which we can see in the X-ray. So with this classical finding of X-ray, it points to the diagnosis of Ewing sarcoma. So the next investigation which our orthopedics colleague do is the biopsy. And on hematoxin eosin stain, it is uniform, small, round blue cell with hyperchromatic nuclei and the clear cytoplasm that we can see here. And in IHC, it expresses high level of MYC2 surface antigen, which is also known as CD19, and it is highly sensitive for Ewing sarcoma, though it may be present in other tumor also. And another potential specific marker which is emerging is NKX 2.2. Coming to the molecular genetics, the hallmark of Ewing sarcoma is reciprocal translocations which involve breakpoint in EWSR1 gene, which is located on 22q. In 85 to 90% of cases, the partner is 11, leading to two translocation 1122. This translocation can be detected by FISH. We can see here this is the normal 11, this is the normal 22, and this is the translocation 1122 depicted by the fusion of the blue and red signals. The transcript can also be detected by the RT-PCR method. So by X-ray findings and biopsy, we confirm the diagnosis of Ewing sarcoma. Ewing sarcoma, around 20% to 25% of patients, they present with metastasis at the time of diagnosis, whereas the rest 80% of patients have localized disease. However, Ewing sarcoma is considered as a systemic disease, so we have to do an extensive metastatic workup, which includes NCCT chest, as it has propensity for lung mets, bone scan, and we also do a peripheral smear, bone marrow aspiration plus bone marrow biopsy, as it can metastasize to marrow also. These three are the metastatic workup, and since we have to plan treatment, and initially the treatment plan is chemotherapy, so we have to do a 2D echocardiography, as we have to administer anthracycline, and we also have to look for the hemogram, liver and kidney function test. We also test for LDH, which is a prognostic marker. Staging Ewing sarcoma is staged as either localized or metastatic. Though TNM classification of soft tissue tumor and bone tumor can be used, but practically Ewing sarcoma is just classified into localized or metastatic. Coming to the basic approach in Ewing's, it is the intent for localized Ewing's is curative, and it consists of three phases of treatment. The first phase is neoadjuvant chemotherapy. It is followed by surgery or radiotherapy of the local site, depending on the site and the tumor characteristic, which we will discuss later. And it is followed by adjuvant chemotherapy. In metastatic Pnet, the intent is palliative in majority of the patient. For palliation, we rely on palliative chemotherapy. In case-to-case selected basis, even in metastatic Pnet, we can go for curative intent. So in those patients, local site surgery or radiation therapy is given. So coming to the chemotherapy aspects, the drugs that are effective in Ewing sarcoma are vincristine, adriamycin or actinomycin D, and cyclophosphamide. So this we call it as VAC in the abbreviated form. And the other two drugs that have been shown to effective are ifosfamide and etoposide. So these are the key drugs which are effective in Ewing sarcoma. So in the first principle of management is that older studies have shown that if we add doxorubicin to the regimen which was used for rhabdomyosarcoma, it was found to have benefit. And subsequent study shows that if we use doxorubicin in the initial part of the chemotherapy, that is in the neoadjuvant time, then there is an improved response. So in the initial part of the treatment, we give adriamycin, and in the later part, we switch to actinomycin D. As adriamycin is a cardiotoxic drug, and we can give it to a certain dose level. After that, we cannot give due to cardiotoxicity. So we switch to actinomycin. So in a landmark study, people thought, why not add ifosfamide and etoposide also to this backbone. So in this trial, we can see that after addition of ifosfamide etoposide, uh, in the experimental arm, which consisted of ifosfamide etoposide, This is the curve in the non-metastatic disease, this violet color, and in this blue color is the standard therapy which consisted of VAC. So there was clear-cut survival benefit in patients who received ifosfamide etoposide in addition to VAC. However, in the metastatic disease, there was no difference even after adding ifosfamide and etoposide. So due to this, it was found that adding ifosfamide and etoposide, there was improved in outcome in non-metastatic disease, but in the metastatic group, there was no benefit of adding ifosfamide and etoposide. So VAC remained the standard of care for metastatic disease, and in localized disease, it was VAC along with I. So the next trial that came, that people thought, okay, we give VAC and I 3 weekly. So why not increase the intensity of the dose by giving it 2 weekly? So they compared 3 weekly VAC-I with 2 weekly VAC-I, and they found that there was event-free survival benefit and the disease-free survival benefit in patients who are given 2 weekly cycles compared to 3 weekly cycles. So, so at present for localized ewings, we give dose dense 2 weekly back alternating with I. For metastatic diseases, I and dose dense has not shown any benefit. VAC is given 3 weekly. This completes our chemotherapy, and this is the standard regimen that we use at our center, and it is used worldwide also. I request Dr. Love Kapoor to thank.
Very good evening, everyone. I'll take you through the principles of surgical management in ewing sarcoma. The limb salvage is now the standard of care. It includes the first part, that is the tumor resection, followed by reconstruction of the skeletal defect. Obtaining adequate margins of resection is always the main aim of surgery. The concept of surgical margins was first described by Enneking, who described 4 types of margins based on the relationship of the plane of dissection of the tumor and its pseudocapsular or reactive zone. So the main aim in malignant tumor resections is to obtain wide or radical margins. Marginal or intralesional margins are not acceptable in such tumors. Now, Enneking did not quantify wide margins. Later, Kawaguchi et al. Classified surgical margins based on the margin distance from the reactive zone and defined wide adequate margin as a normal cuff of tissue of more than 1 to 4 centimeters. He also described the concept of barriers, which is defined as any tissue that has any resistance against tumor invasion. So these barriers are converted into equivalent thickness of a normal tissue. The barriers are of 3 types. First is a thin barrier consisting of weaker membranous structures that is equivalent to a 2 centimeters of margin. Thick barriers consisting of strong membranous structures equivalent to 3 centimeters margin, and joint cartilage equivalent to 5 centimeters of margin. The various reconstruction options can be broadly classified into biological reconstructions and endoprosthetic reconstructions. The biological reconstructions include recycled tumor-bearing autograft post-sterilization, that is after treatment with extracorporeal radiation therapy or liquid nitrogen or autoclaving or pasteurization. Use of vascularized or non-vascularized fibula, allograft, which is dependent on a bone bank facility, and cement spacers. Now, since ewing is primarily a tumor of the diaphysis, extracorporeal radiation therapy has a very key role in reconstructions. This includes reimplantation of the patient's own bone post-sterilization with a high dose of irradiation. This is primarily used in diaphyseal tumors which have not crossed the growth plates, without any pathological fractures, and with good quality of bone preserved. So this was a study from our institute in collaboration with IIT Delhi, which evaluated the biomechanical evaluation of the irradiated bone, and this showed that the irradiated bone is weaker and more porous and stiffer, brittle with mechanical denaturing. However, the irradiated autogenic bone retains most of their biological potential. The surgical technique involves the tumor resection followed by soft tissue stripping. The tumor-bearing bone is then washed thoroughly and packed in a vancomycin-soaked sponge and then sealed airtight in polythene sheets. This is then sent for extracorporeal radiation therapy, and upon receiving it back in the OT, we again wash the tumor-bearing bones thoroughly. In most of the cases, we pass an intramedullary fibula, and then this construct is fixed, is reimplanted using a suitable fixation devices. Now, what we do differently is we use a stable osteotomy geometry like the V-shaped or a step cut osteotomy. Secondly, we place an intramedullary fibula to add to the strength of the irradiated bone, and we used dual plating in the lower limbs. You can see in this, there's a callus can be seen as early as 6 months. So this is an example of a 10-year-old with the ewings of the distal femur. Patient underwent wide resection, followed by extracorporeal radiation therapy and reimplantation. These are the post-operative X-rays at 4 years, showing good graft incorporation and good clinical function. Another example of a 22-year-old with ewings of the right hemipelvis. The wide resection was performed, and the bone was then again irradiated and reimplanted back. This is the post-operative X-rays at 3 years. On an analysis of 51 patients from 2011 to 2020, which included 65% of Ewing's sarcoma, uneventful union was achieved in 83% of the patients with an average time to union of 8.6 months, and good to excellent functional outcome was achieved. Now, some of the factors which significantly affected the time to union were age less than 20 years, use of a V-shaped osteotomy, and use of additional plates. Local recurrence occurred in about 13.7% of the patients, and all these recurrences were in the soft tissue, no recurrences in the irradiated bone. So this reiterates the oncological safety of the procedure. Another useful modality of reconstruction is the use of fibula. Both vascularized and non-vascularized fibula can be used for various reconstructions of the upper limb and the upper and the lower extremities. So this is an example of ewings of tibia in a 7-year-old male. Wide dissection was performed, and the ipsilateral fibula was translocated. These are the post-operative X-rays at 22 months follow-up. You can see the remodeled fibula and the hypertrophy of the graft, and the patient is able to walk full weight bearing. We recently published a series of pelvic tumors, of which a total of 82 patients, of which 24 were Ewing's sarcoma. We did a hip transposition procedure for these patients. One such example is the Ewing's of the right ilium. Transacetubular type 1 plus half resection was performed, and the femoral head was transposed to the remaining acetabulum using a Prolene mesh. This was the immediate post-operative X-ray showing a balanced suspension of the extremity, and the follow-up X-rays at 20 months. The patient was able to walk full weight bearing without any support, although with some lurch. So for osteoarticular resections in tumors crossing the growth plate, the endoprosthetic reconstructions form a suitable reconstructions. These provide a stable construct and allow immediate weight bearing with preservation of joint range of motion. In some cases, due to extensive involvement of the disease, it requires radical resections. Like in this case, the total femur had to be resected and reconstructed with a total femur megaprosthesis. The reconstruction in growing age group presents a unique challenge as the growth plate is sacrificed, and this can result in limb length discrepancies. So, expandable or growing endoprosthesis provide a suitable reconstruction option for this, which can be lengthened using minimally invasive methods at intervals to match the contralateral limb. However, they are very costly. So, the cement spacers, they provide a cost-effective alternate to the endoprosthetic reconstructions, which provide a stable construct, and although at the expense of limb lengths and joint range of motion. Thank you. I would like to invite Professor D.N. Sharma for the later talks. Thank you.
Dr. Love, good afternoon, everybody. I will briefly take you through the role of radiotherapy in the Ewing sarcoma family of tumors. After the neoadjuvant chemotherapy, when the patient is operated, if the patient has microscopic margins positive or the gross residual disease, then RT is indicated, and usually the dose is 50 to 55 gray. Sometimes because of the site of the tumor, the patient may not be operable, and for these patients, there is no surgery possible. So we deliver the definitive radiation, which we call as the sole radiation treatment. The dose required is usually 55 to 60 gray. For incurable patients, when the patients have devastating symptoms, the radiation is very effective because biologically the Ewing sarcoma is a sensitive tumor. Whenever the RT is indicated for any setting, the radiation is very, very effective. But dose, of course, varies from situation to situation. Like sometimes maybe 8 grays enough, sometimes 25 is required. And for metastasis, even for a cure, even for metastasis, the RT is required in a curative setting for the whole lung radiation treatment called the lung bath. The dose usually required is 15 to 18 gray. I will bit emphasizing on the because role of radiation for in general is for Ewing sarcoma is very straightforward, very simple. There are not many controversies. I will bit emphasize on the extracorporeal because although Dr. Now has already mentioned, but I will be emphasizing the radiation component of the ECRT treatment. Extracorporeal radiation is actually the radiation treatment when the part of the body is taken out from the body and given radiation and then implanted back. That we call it extracorporeal. And in this, as Dr. Now has said, the en bloc tumor bearing bone is removed from the body, tumor is resected, and then it is given a high dose of radiation, usually 50 to 300 gray. This dose is actually enough for slicing the viable tumor cells in the bone and that bearing bone, and then it's implanted back into the body. The rationale is that it is very convenient because otherwise you will be using a prosthesis which is very costly. It is a foreign body. Sometimes it has a reaction and it has a it might some loosen up in the due course of time. So it is patient's own bone which is being used as a prosthesis, and it is very convenient, very cost effective, and patients do not psychologically do not have a feeling that something foreign body has implanted into the body. Although literature is very sparse, in fact, we were the first one, probably first one in the country to start this innovative treatment. Although all sarcomas are, we give ECRT, but for today's we'll discuss only the Ewing sarcoma. As Dr. Love said, the patients having extensive bone destruction as an osteolytic process, they are contraindicated, pathological fracture, and major neuromuscular bundle involvement, which is actually contained for the limb salvage. Technique, I can just come to the the doses have been in the range of 50 to 300 gray. Initially, people started with 300 gray because that is the dose which usually sterilizes the entire tumor cells. But it has been found that if you give a high dose, then the quality of the bone, remaining bone, is very fragile, and becomes very brittle. So patients usually they have pathologic fractures post treatment. So it was abandoned, and nowadays many people give only 50 gray or maybe 100 gray. We decided to give 50 gray because that takes less time, and it kills almost 100% of the tumor cells. This is how we do it. This is one of the patients which we have treated. Remember that when we do the extracorporeal radiotherapy, the patient is still in the operation theater. So we need to be quick, and there is a lot of coordination required. The bone is taken out, it is packed into it is wrapped into the sheets, and then it is transported onto the radiation department where the machine is being kept as unengaged, because if we take more time, then the patient will be still under anesthesia, will have a lot of infection. There has been a risk of the infections if the treatment time is more. So we need to be very quick, and this is how we give the radiation treatment to the segment of the bone which was wrapped into the sheet, and then on the bolus material. Usually the linac has a skin sparing effect. So if you do not wrap in this kind of material, then the part of the bone might be underdosed and we might not kill all the cells. So we usually wrap around like 2 centimeter plus thickness material like this, and then we keep on the treatment is very, very simple because here there is no normal tissues, there is no body, and treatment is actually very, very simple in this way. One of the patients, maybe the same picture Dr. Love has shown, and this is another patient where this bone was reimplanted back, and you can see the movement of the patient. Patient can have the full range of the movements, even the post treatment, post TCR. Advantage being the preservation of the range of movement of the joint, as I showed, restoration of the normal mass of the bone, evidence of the early and late loosening of the bone, and the prosthesis leak breakage, because if we give prosthesis externally, then there might be breakage of the prosthesis, and the risk of local recurrence has been found very, very low, maybe 3 to 5% in the literature. Our experience in the beginning was not very good, but then in the beginning we planned only a feasibility study. Infection was the most common complication in our series, followed by the fracture in some patients, and the other complaint being the avascular necrosis and the non-union. small data in the beginning. We started way back in 2007. Dr. Rastogi, Salam Khan, myself, and Dr. Samir, we all started this together. This was a that time there was not much of the literature also. So this is the initial experience just to see that whether we are going the right or wrong direction. 14 patients, mostly were the osteosarcomas, 5 patients having sarcomas, and then primary site location was femur 8, tibia 5, mostly the extremities. And median time was, this time is very important, median time was 50 minutes, although it ranged from 40 minutes to 95 minutes. Initially, we took a lot of time because when we started the treatment on the cobalt machine, it used to take a very, very long time. Sometimes it used to take as high as like 1.5 hours, But off late, it takes, in fact, today our morning also we had a patient of ECRT. It takes now only 40 minutes because now everything has been coordinated well. Local control was like 80%. We did not look much at the local control because it was only a feasibility study. Initially, we had few hurdles also, so we did not give too much emphasis on the local control. But overall, the results were good in the sense that the 2-year local recurrence-free survival was 73%, and only 2%, 2 patients had the wound infection in the perioperative period. Thank you very much. Okay, Dr. Archana.
Good afternoon to one and all. Now Dr. Raghav and I will take you briefly through the 15-year journey that is PNET at IRCH. So during this period of 15 years, there were 1,032 patients with PNET who were registered at our center. These primarily belonged to the adolescent and young adult age group with a median age of 15 years. They presented with a median symptom duration of approximately 4 months, which is a little longer than that described in Western cohorts, which is of the range of around 2 months. The most common site that we observed was, as expected, the extremities, with 40% of tumors belonging to this site, followed by the thorax, which accounted for 20% of all PNETs that we saw. An alarming 40% of patients had metastatic disease at baseline presentation, which is significantly higher than the 20 to 25% reported in Western cohorts. So our patients all received systemic therapy as per the protocol described by Deepam sir. Local therapy was administered in 50% of this cohort, including surgery alone in 30%, radiotherapy alone in 15%, and a combination of the two in 7.2% of patients. With this, we achieved results which are as follows. Patients were likely to survive for, at a period of 3 years following initiation of treatment. In a localized cohort, we could expect around 60% of patients to be alive and on follow-up. These patients had a median overall survival of around 4 years. However, in a metastatic cohort, the 3-year overall survival was in the range of 25%, with a median overall survival of 1.5 years. We divided our entire cohort into two, one being a derivation cohort, wherein we tried to look at what clinical factors at baseline would help us to predict for event-free and overall survival. So this was basically designed to help a clinician understand when they see a patient at baseline presentation, what factors should they look into to be able to predict survival later on. So we found that size more than 5 centimeter and presence of metastasis were associated with inferior event-free as well as overall survival. Apart from this, we also found leukocytosis with a total leukocyte count of more than 11,000 to be associated with inferior survival outcomes. While the first two are expected, size and presence of metastasis, total leukocyte count probably is also a prognostic factor, because leukocytosis means that the tumor is likely to be of a more aggressive biology, and therefore it was also found to be a prognostic marker. So we used these 3 prognostic markers and formulated a score, an Ewing sarcoma prognostic score, which would help us divide patients into 3 categories: a low risk, intermediate risk, and high risk categories. And we applied this onto a separate validation cohort. So we found that in our validation cohort, between the 3 risk groups, survival outcomes were significantly different, thus helping us validate our score and making it a potential tool for clinicians to use. So next, I would like to describe some of the site-specific issues faced during management of PNET. So as previously described, extremity accounted for 40%, chest wall for 20%, head and neck for 11%, and spinal PNET for 7% of our entire cohort. So head and neck we found was a relatively favorable site. Why? Because probably because of the cosmetic and functional impact of tumors being in the head and neck, patients tended to present relatively early with more localized disease. Thus, the survival outcomes were better. Despite this, local control is actually quite a difficult task in head and neck PNET because of the surgical resectability being quite difficult. So often in many patients we end up using radiotherapy as a curative local modality. We found in our cohort that patients who received surgery alone tended to perform poorly as compared to patients who received a combination of surgery plus radiotherapy. So the dictum here is probably radiotherapy needs to be used in most patients with surgery where resectability is possible. So next, in our chest wall PNET cohort, chest wall PNETs are also arise from an area where resectability can occasionally be difficult because of invasiveness of local structures. So so many of our patients had to be were treated with radical radiotherapy as well. When we compared the two groups, we found that patients treated with radical radiotherapy performed relatively poorer compared to a combination of surgery with or without radiotherapy. So our moral from this is that radiotherapy is can be given to these patients, but always attempt surgery when possible, plus or minus radiotherapy. So next we are discussing the cohort of patients with spinal PNET. So spinal PNET represents a particularly bad site of disease because most of our patients present to us with paraparesis, with poor performance status and in a bedbound state, and often not fit for high dose chemotherapy as well. So we found that a large number of patients, 20% in our cohort, had been misdiagnosed with spinal tuberculosis and in fact had received anti-tubercular therapy at presentation. So this is an issue unique to our country, which may lead to delayed presentation and might or might not compromise survival. So the outcomes in this particular subset are so bad that localized survival in localized disease is as bad as that in metastatic disease. We found in our entire cohort that even metastasis did not predict for survival. It was only serum albumin, which is a marker of being chronically ill for a prolonged period, that was found to be a prognostic marker for survival. So next, moving on to extremity PNET, which is the most common form. Herein in extremity PNET, it is quite simple that surgery is the preferred modality. We found in our cohort that patients who did not receive surgery performed poorly, and those who receive surgery, basically surgery is essential for extremity PNET with or without radiotherapy where required. So next, I would like to call upon Dr. Raghav to tell us a little about what happened to our patients when the disease relapses.
Good afternoon, everyone. Today, I'll be presenting the part on the relapse as well as the survivorship care in Ewing sarcoma survivors. International data has shown that the survival in case of relapsed Ewing cases, evaluation had shown that a median OS of about 20 months in these cases. Now, the impact of time to relapse. Time to relapse in a case of a relapsed Ewing sarcoma case is an important prognostic factor, where patients who had a relapse-free interval beyond 2 years had fared significantly better when compared to patients who had relapsed prior to 2 years. Coming to the effect of site of relapse on the survival outcomes in case of relapse Ewing sarcoma cases, patients who had a local relapse fared comparatively better compared to those of systemic relapse, and the patients with both local and systemic relapse fared the worst. Now, coming to the site of the systemic relapse as a prognostic factor, patients who had lung-only metastasis did better when compared to bone metastasis, and patients with multisystem involvement at relapse had fared the worst. Now, coming to our own institute experience, here when we have analyzed the data of 115 patients of Ewing sarcoma relapse cases, We have seen that the time to relapse of more than 2 years were compared to those with less than 2 years. And we found that there is a statistically significant improvement in the overall survival of the patients who had relapsed later at a time point of more than 2 years. And here when we see the type of relapses, patients with local relapses did better when compared to distant relapses. However, patients with local and distant relapses fared the worst. Coming to the late effects and the survivorship care of sarcoma survivors. Survivorship care basically begins at the time of the diagnosis of the cancer and prolongs to the extends to the end of life. Survivorship care includes not only the rehabilitation process but also the physical, the mental, emotional, social, and the vocational outcomes of these patients. So in our study, we had focused on the psychosocial, functional, as well as challenges in schooling, vocation, as well as the fertility issues in Ewing sarcoma survivors. Now, we had done the quality of life assessment and by using the URTC QLQ C30 proforma, and we found that coming to the three main domains of physical functioning, cognitive functioning, and the global quality of life, our survivors with Ewing sarcoma had fared worse when compared to the control group, which were the siblings. Now we had also compared them against historical cohorts of the largest study where they had also measured the quality of life outcomes, and compared to those studies also our survivors had done worse compared to them. So there was a significant difference in the physical, cognitive function and the global quality of life in survivors compared to the siblings. The fear of a disease relapse as well as the fact difficulty in finding vocation after treatment was the main reasons that had contributed to the poor global quality of life in these sarcoma survivors. We had also measured the anxiety and depression outcomes using the hospital anxiety and depression score. And out of the 25 Pnets survivors, we had identified that 7 patients, that is almost 28% of the cohort, were found to have either borderline score or an abnormal score and were further sent for evaluation and help. Coming to the fertility outcomes in our survivors, we had screened 103 extremity bone sarcoma survivors, of which 25 were Pnet survivors. At the time of interview, one patient among the 25 had reported infertility via both biochemical as well as the further testing. On evaluation of the rest of the survivors, 2 patients, that is 8% of the cohort, was found to have biochemical evidence of infertility, and then we had subjected to them further testing after consent, and they were found to have infertility. Now I hand over to Professor Samir Bakshi, sir.
Thank you all. So, having shared this data over 15 years, I'll just try and summarize some of the facts. So, bone sarcomas, interestingly, or I would say uninterestingly, for last 30 years, there has hardly been any change in the treatment. From 1990 to 2022 now, the drugs are essentially the same. Maybe we have got better at using the same drugs. We have got better in supportive care, but there is no new drug, no targeted therapy, no immunotherapy. It's the same drugs. We may have got better at surgery and in the supportive care. And that's what we have done as well. We have used the same standard therapy and the world that practices, but what we have achieved is a good multidisciplinary teamwork, and that's thanks to All India Institute where we work. And we have learned from our own experience. I also want to tell you how we have learned. If we look at, we have 2 survival curves of our cohort. The first 9 or 10 years of our experience from what we have, and now in the last 7 or 8 years, we are better by almost 12 to 15% survival. That gain of 15% is not due to new drugs, but due to better supportive care and better coordination with our collaborators and my research team that I'll talk about. We have been able to establish outcomes in one of the largest cohort from a single center both in localized and metastatic setting. And we have been able to establish site-wise experience, which has kind of brought out unique issues in various sites. As Archana brought out, that in thoracic PNET, surgery is always preferred. In head and neck PNET, radiotherapy is as good as surgery, or maybe even sometimes better, because of the cosmetic effects associated with the surgical intervention. Same is true for the orbital PNETs as well. We have also been able to show the site-specific effect in the pelvic PNET, where most of our patients did very poorly. The reason being that in pelvis, the tumor continues to grow and the patient doesn't come to know, unless at the time when it has grown to beyond 10 or 15 centimeters. And as I said, large size of the tumor is a bad prognostic factor. Virtually every pelvic tumor is more than 8 to 10 centimeters. Hardly ever one would see a less than 5 centimeter tumor in the pelvis. Extraosseous Ewing sarcoma has done better than the skeletal Ewing sarcoma in our cohort. We have also been able to establish novel tools for prognostication, and I call this novel because we were the first ones to establish this. The ratio of the neutrophils to lymphocyte as an independent prognostic factor in Ewing sarcoma to be a poor prognostic factor. And this was published very recently by Archana and team, which validated this scoring system using first a derivation cohort and then validating it in a large patient cohort of 860 patients. We have also learned from imaging. We have learned that the use of PET scans on follow-up does pick up recurrences earlier, although I will not say that we can show an impact of this pickup. We also looked at social issues of diagnostic delays. Amongst the bone sarcomas, the diagnostic interval in Ewing sarcoma was longer than that of osteosarcoma, and the prime reason being that osteosarcoma was primarily in the extremities, whereas Ewing sarcoma involved other sites as well, like the pelvis, the chest, where things are sometimes picked up much later than in the extremities. Age above 15 years was a factor which actually predicted a prolonged diagnostic interval. Surprisingly, even with a delayed diagnosis in sarcomas, the outcome was not different from those who were picked up earlier. We have just submitted this manuscript and we are waiting as to what, but it is very, very interesting. Late diagnosis in sarcoma doesn't mean that the outcome is bad. We have worked on some lab aspects. We have looked at the circulatory T regulatory cells in Ewing sarcoma, and we found that at diagnosis, they were higher. They fall with the neoadjuvant therapy, and they again rise on progression and relapse, although there was no impact on survival. I would, however, confess that we have overall lacked in our laboratory work related to Ewing sarcoma. Metastatic Ewing sarcoma unfortunately forms 40% of our cohort compared to the 20% cohort that is seen in the Western world. The metastatic Ewings is unfortunately a very bad disease. Metastatic osteo, you can still expect a 40% survival provided the metastases are 3 or less. But in metastatic Ewings, unfortunately, the outcome is almost always below 20% in the metastatic setting, and most of them are only palliative. We found that those with hypoalbuminemia were extremely bad, and every single case with hypoalbuminemia and metastasis, none of the patients survived. So we know that that cohort certainly is not going to make it, and they should be options for some milder form of therapy rather than subjecting them to aggressive forms of treatment. I want to just introduce this form of therapy. This is a metronome for those of you who play musical instruments, and metronomic anti-angiogenic therapy using thalidomide, celecoxib, cycloine, etoposide has been what we have been working on it for last 7 or 8 years now. And Dr. Raja did this landmark trial where he showed that in patients who have failed 2 lines of treatment, metronomic therapy was as good or as bad as placebo. But what we found was that in non-bone sarcomas, that is the soft tissue sarcomas, soft tissue PNETs, rhabdomyosarcoma, this form of therapy was effective as a mode of treatment. This we published in JAMA Oncology in 2017. And we have recently shown that oral metronomic therapy is as effective as pazopanib in advanced adult soft tissue sarcomas. It's an oral form of therapy, very cheap and practically non-toxic, and as effective as very expensive modes of treatment. I would conclude by saying that we perhaps need to explore the role of this oral metronomic therapy in metastatic ewings for progression-free survival and perhaps the quality of life. Instead of, and now with the risk categorization, we need to see if we can de-escalate in some of the low-risk patients, and we need to strengthen our survivorship care, which we are working on currently with a new project on cancer survivorship. I want to thank the medical oncology research team. I want to show, I don't know how the pointer, Dr. Bivas Biswas, who's on the right side of the screen, he's now in Kolkata, but I give him a lot of credit for a significant amount of work that has come on this tumor. He worked very hard on this tumor, and even when he joined as faculty for a few months at our institute, he did a lot of work on this tumor. He's currently in Kolkata. The 10 or 15% gain that you saw in the outcomes over a period of time is due to my research team, which actually works on calling the patients, tracking them, finding out where they are, if they miss their OPDs, and all that credit goes to them. I also want to thank our surgical and radiotherapy teams who help us with various aspects of the surgical and radiotherapy aspects. I wish I had a picture where I had a composite picture, like we have a family photograph, but I didn't have all of them, and I had to get these pictures from the online Google site, and some of the pictures I couldn't get. So there are more surgeons than this that I have shown here, more radiotherapists, but I could only get few of the pictures. Likewise, our diagnostic team, Dr. Thulkar, but Dr. Thulkar, I couldn't get your picture online, so your picture is not here. So the diagnostic team, which actually helps us in getting our diagnosis, our pathologists whom we keep bothering them so on, and without them we can't really get anything. And the biggest thank is, this team is due to this place, this picture, institute, where we are able to get all these people under one roof. I also want to thank 3 other seniors from our department. Dr. Vinod Kochupillai actually entrusted me with this responsibility 20 years back. And she said, you look after sarcomas, there is no taker for sarcoma. And that's where the journey started for sarcomas 20 years back. And Dr. Kochupillai was the one who said, nobody looks after. I still remember Dr. Deo telling me that time, we do the surgeries, but nobody looks after chemotherapy. So that's where the journey started. And then Dr. Rena was very, very supportive, and he was a great clinician. You could go to him, ask him, and his wisdom was something that we all miss. Dr. Atul Sharma is not here today and he is not well today, so he couldn't come. He's a great friend, a great senior, and he guides me so often on my day-to-day issues for various patient-related matters. And once I talk to him, I get the confidence that I'm on the right path. Thank you all. Thank you all for being here. Thank you very much. We will now have the questions. Yes.
The prognosis in sarcomas after treatment, is it different than, is it actually due to the metastatic disease, or is it due to therapeutic adverse effects, or is it due to cardiotoxicity of the drugs leading to sudden cardiac death? Do you have any
The
idea?
last part I didn't hear.
The
Cardiotoxicity.
cardiotoxicity of these drugs, because some of the literature I came to know that the cause of death, especially in these kind of chemotherapeutic agents, are adverse effect is cardiotoxicity leading to cardiac death. So do you have any experience on this, sir?
So, biologically, a metastatic disease is bad. In Ewing sarcoma, if it is metastatic, no matter how much intensification you may do, you may add ifosfamide, etoposide, you may even do a transplant. There was a very recent paper just this year. People have done transplants in metastatic Ewings and there is no impact. So that tells you that the disease biologically is bad. And that's exactly what we found as well. The toxic deaths in Ewing sarcoma is not a very big fraction. While it's a toxic form of therapy, so I would say the 15% improvement that we have had from the first 10 years to the next 10 years, that 15% improvement, partly it is due to getting better at curtailing the toxic deaths. So that's the second part. The third part, late deaths due to cardiotoxicity. Well, I'll say, I think, at least personally, I need to get still older to see those very late deaths. And I think I need to wait another 10 to 15 years to see those very late deaths. We have had occasional secondary leukemias, but the numbers are very small. I would say 3 out of 1,000. So that's a very small number. I don't remember personally losing a patient of Ewing sarcoma to cardiotoxicity, but it is said that cardiac toxicity can manifest even 20 years later. So we still need to wait a little bit longer. So renal PNET is like a soft tissue PNET. If it is metastatic, it will behave exactly like a metastatic PNET. That means very bad. If it's localized, it will behave well and one can expect a 60 to 65% long-term cure rate.
Biopsy. Is there any role of surgery or still you have to do surgery?
I would say that we should do removal of the kidney. Personally, in a sarcoma, if you look at the general dictum of sarcoma, it is that you remove the tumor. That is the general dictum. So I would probably consider doing surgery and not leaving it inside. Maybe Dr. Deo can share and shed more light on this aspect.
Congratulations, Dr. Samir and your team for a fantastic grand round. I would absolutely agree with you. This is, I think, one solid tumor where I think the chemotherapy has made a big impact. So before the era, we used to chest wall PNETs, most of them were declared inoperable. But the responses, what I would call this actually surgery is the adjuvant in Ewings. Most of the time, we call chemo and radiotherapy as adjuvant, but for Ewings, I would always feel and believe surgery is adjuvant. Just remove the residual core tumor after chemotherapy takes up all the systemic disease. So the big impact what we have seen is in the chest wall tumors, Ewings. The big difference now, most of the patients are undergoing routine surgeries with R0 resections. And I think the major impact is because of the systemic therapy. For renal, I think, again, I agree with you. The primary removal is, I think, the cornerstone. So we need to remove that.
So one would like to remove. I think Dr. Deo also seems to agree on the same thing. So we just have a colleague from gynecology has shared a tumor of the uterus having Ewing sarcoma, and we just had a discussion yesterday that we would perhaps first give chemotherapy because it is exquisitely sensitive. It will regress. Yes.
Yeah, I told.
Yes,
I
we
was
had.
already
Yes.
earlier part. You might have discussed it earlier. In the female genital tract, how often do you see penis?
Very rare.
Very,
I
very
would
rare.
not think it's not certainly a common sight. It can. I mean, we see rare sites, and this is one of them. Like just,
This presented like a sarcoma botoroides, you know, like a mucosal rhabdomyosarcoma.
I mean, that would be the main differential diagnosis.
Yeah.
Just the other day, we had a tumor in the brain, and it was reported from pathology as a PNET. And I said, a brain tumor PNET, I mean, inside. But then we checked with the radiology that it is actually arising from the dura. It is actually from the bony dura. It's not a brain tumor primarily. So we get
This particular case, you will be treating chemo first.
Yes, absolutely. That's what we do. We would like to get it down. The tumor will shrink. The surgery will be simpler, and you take care of the so-called micrometastasis.
PNETs. So kidney PNETs work the way you looked at the bone tumors. The majority of kidney tumors we get these days are localized, and therefore if they are localized, they'll undergo a nephrectomy first. They may or may not get anything additional subsequent to that, but they would all get a nephrectomy up front if it's a localized disease to the kidney, and we get quite a few PNETs. It's when we get those large tumors which don't fit into a classic RCC appearance that they'll end up getting a biopsy. Otherwise, kidney tumors do not get a biopsy. When it's a larger tumor which doesn't look classically like an RCC, that it would get a biopsy with the hope that it's a PNET, because then that would respond to a chemo. So those are the renal tumors where we would do a chemo up front. But if it's a classic localized kidney tumor, surgery would come first.
I think that's perfectly fine. If it can be resected easily, then it's not a problem. But I think they need adjuvant treatment. I would just say that they need adjuvant and not just sent home. So that is one of the learning points.
The point against the RCC is the young age. And the second is the almost, I don't remember, to my mind, almost all of them shows the renal vein invasion or thrombosis.
Young age is certainly one. Young age with large tumors is two. Large tumors in general where the imaging features are not characteristic of an RCC. Because if it's a large tumor with a locally advanced disease and it's not an RCC, it's very little we can do. On the other hand, if it turns out to be a PNET, it would respond. So that's where they would get a biopsy. The background to this is to say we don't biopsy kidney tumors. Kidney tumors are diagnosed on imaging and treated on imaging without a preoperative biopsy in the large majority. But this is one tumor where if you have a suspicion up front that this is a PNET, you would biopsy it. Why I say it subsequently. Yeah, we have a common clinic, they get referred to that common clinic.
Aditya,
So, in the relapsed and refractory setting, any experience you have with autologous transplants in PNATs?
So I have done transplants in relapse setting. My advice would be that those who relapse beyond 2 years in Ewing sarcoma and go into remission are candidates for undergoing autologous transplant. I personally don't think that those who relapse before 2 years from the initial diagnosis, transplant would benefit. That's my personal viewpoint, and our own experience is matching that of the Western world as well. That those who progress in the first 24 months from initial diagnosis, the survival is less than 10%. But those above, so they are candidates for transplant. Yes. I didn't hear it. Sorry, there a mic then.
Why there is predilection for in the second decade?
Why there is predilection in the second decade for these tumors? So one of the reasons for the bone tumors having predilection in the second decade is they kind of coincide with the growth spurt. So that is said for osteosarcoma, and that with the growth spurt, the tumors increase. In fact, there is also data that taller the people, higher, I mean, they have more incidence of osteosarcoma. So it is something to do with the growth spurt. But osteosarcoma also has a spurt later on in the life. For Ewing's, I'll also say there is a early, there's, I won't say peak, but you get significant number of patients even below 6 or 7 years. So you have significant patients below 6, 7 years, then 15 to 20 years, 15 to 30 years, and it goes on till around, say, 40 years. I also want to acknowledge our research team from IIT, to Dr. Amit Mehendiratta, with whom we work together on various imaging aspects of the bone sarcomas. And to Dr. Isha and Dr. Amit Mehendiratta, we work with them. So that's another aspect of the tumor imaging that we have been working on.
Very nice presentation. One question that I have is that in the cohort that you showed, like infertility was a major late effect that was documented.
Infertility was a
major late effect that was documented. So are we resorting to some fertility preservation techniques, etc.? Have we started that in our patients? And if so, what are we currently?
So actually, surprisingly, I expected the infertility to be much higher, but with so much ifosfamide and cyclophosphamide being used, but our data suggests that it is 20% with even the biochemical parameters and everything. We have been so far been able to find it in 20%. Personally, I expected it to be higher. One, I would like to get fertility issues, I mean, to get the semen preservation and the ova preservation done. The problem with a lot of these patients is that we get presentation beyond 4 months. While it may not impact the prognosis, but sometimes a lot of these patients are with a fracture, bed bound, on a wheelchair, in lot of pain. And asking those patients that time to go for semen preservation seems very unreasonable. It appears okay on a thing to say that, okay, we will get semen preservation done. But asking a patient who is howling in pain, we are sending for morphine, and who is on a bed, asking him to go for semen preservation gets very unreasonable for that patient. So the first step is to get his pain controlled with chemotherapy. So that is the problem that we face. I wish we had patients who came with Ewing's, walk in and say, doc, I have some swelling in my knee joint. But we don't get many of those. When we get those kind of patients, or they are not in a bad state and they are above a certain age, we encourage them to go for the preservation of their eggs. Thank you very much. Thank you all.